Hello everyone and welcome to another session of Next Saviours Essential Question Series for NEET PG 2025. Today we are going to have a discussion on the investigations which are required in order to manage this case of a stroke, the investigations and the importance of NCCT, the CTA and the CTP will be talking about in relevance to a question related to this phenomena. Now, a 68-year-old male with a history of hypertension and atrial fibrillation. Now, when you see this, it is a hint provided to you in the question that the patient might be having increased risk for cardioembolic stroke. If you further read the question, that he presents to the emergency department with the right-sided hemiparesis and dysarthria for the past 2 hours. It is suggestive of middle cerebral artery occlusion. So the 2 points are obviously clear by reading the first two lines in the question, that the patient is having a risk for the cardioembolism and the patient might be presenting with the middle cerebral artery occlusion. Now, his NIHSS score is 8. Now, what is this National Institute of Health stroke scale? This is a clinical tool which is used to objectively quantify the severity of the stroke. So it is widely used in acute stroke assessment, designing the prognosis, and guiding the management decisions. If we look about the components which are being tested in this NIHS score, then the category involves the loss of consciousness, the gaze, the visual field, facial palsy, the motor functions of both the lower limbs and the upper limbs, the limb ataxia, the sensory system, the language, dysarthria, and inattention. And these categories are further divided into the score based upon the tested functions. And the scores are interpreted. For example, if the score is 0, it means the stroke severity is that there is no stroke symptoms. If the score is lying in between 1 and 4, it is suggestive of minor stroke. If the score system is in between 5 to 15, it is suggestive of moderate score. 16 to 20, moderate to severe, while more than 21 is severe stroke. And this helps in defining the management of the patient. Like if the patient is presenting with more than 21 score, then it is associated with poor prognosis. And thrombectomy is indicated when the large vessel occlusion is seen, but it is associated with poor prognosis because the core infarct area obviously would be larger. On the other hand, if the score is in between 16 to 20, then consider thrombectomy if there is a large vessel occlusion. If the score is in between 5 to 15, then the patient is a candidate for the management by thrombolysis, which is alteplase. If the patient is suffering from minor stroke, then he may or may not require thrombolysis, but it is not the only criteria for deciding the management. This is just a clinical suggestion. It is a help. The management would be based on identifications on the imagings. Now, if you read the question back, then his NIHSS score is 8. That means the patient is lying in moderate to severe sort of ischemia. Now, the first investigation which was conducted is the non-contrast CT of the brain shows no evidence of the hemorrhage. Now, this is important because from here, the real essence of the question now comes into play. You are presenting with a patient who might be suffering from ischemia, and he comes within a window of less than 4.5 hours. That means the patient is presented early, so it requires a prompt management. Now, first thing that you have to go for is doing the NCCT scan. Why NCCT of the head? Because you have to identify whether the hemorrhage is present or not. Because if the CT shows the presence of the hemorrhage, then it is a contraindication for thrombolysis and the management differs. But if the patient is presenting with the no hemorrhage, that means if the patient is presenting with the ischemic features, then there are two possibilities. One possibility is that there are no changes at all, and this is a greater possibility because the patient is presenting in a acute phase, in a early phase of less than 6 hours. So majority of the times the CT scan appears to be normal. But if the patient is presenting after 6 hours, then some of the findings related to ischemia might be present. And these findings, as you already know, are the loss of gray and white differentiation, the sulcal effacement. But here in our question, the NCCT head shows no evidence of hemorrhage. That's it. And no features of ischemia are provided to you. Now, the next step for you in order to manage this patient is that, okay, the patient is presenting with ischemia then, possibly, then first thing that you have to identify is that whether there is a large vessel occlusion or not. So how will you identify this? It is based on CTA, that means CT angiography. Now on the basis of the CTA, we will identify that the large vessel occlusion is present or it is not, because it will help you in deciding the management whether mechanical thrombectomy can be done or not. Imagine if the patient, like in this case, there is a clear cut evidence of a large vessel, that means middle cerebral artery occlusion present on the CTA. So this is the patient who is a candidate for mechanical thrombectomy. But had there been no large vessel occlusion, only a small vessel occlusion is there, then in some of the cases only TPA, that is intravenous TPA thrombolysis, might suffice or would suffice. Okay, so this is the importance of CTA imaging. Now, once you are done with the CTA imaging, the next thing that you have to look for is that during this course of ischemia, is there any brain tissue left alive or not? That means if there is an infarct, then whether to perform this mechanical thrombectomy would be of any help or not. And this has to be decided on CT perfusion, because this CT perfusion, it differentiates between the core infarct and the penumbra. As you know, that penumbra is a salvageable brain tissue, while core infarct is irreversibly damaged brain tissue. So this distinction is to be done on CT perfusion. So what are the parameters? The first parameter is cerebral blood flow. In case of a stroke, there will be a decreased cerebral blood flow in infarcted and ischemic regions. While the cerebral blood volume in a stroke, it will be severely decreased in infarcted core, while it will be preserved in penumbra, that is salvageable brain tissue. The mean transit time is actually a time for blood to pass through the brain tissue, which is counted in seconds. It is obviously, in case of stroke, it will be increased, prolonged in both infarct core and penumbra, while the time to peak is actually the time for contrast to reach the peak concentration, which in case of stroke is also increased or delayed in ischemic region. So these are the four parameters that are looked upon in case of CT perfusion. And what are their interpretations in case of core infarct or irreversibly damaged tissue? That cerebral blood flow and cerebral blood volume both are severely decreased, the MTT is prolonged, and CT appearance in case of infarct tissue, it would appear dark or hypoperfused. While in case of penumbra, where there is a presence of salvageable brain tissue, the cerebral blood flow is mildly reduced while the cerebral blood volume is preserved. The MTT will obviously be prolonged, and there will be a feature of mismatched hypoperfusion on the CTP appearances. And this is how the CTP appears. Like if you look at this image, there is a presence of dark purple region in the left hemisphere, which is signifying the reduced blood flow in the middle cerebral artery territory. So it is suggestive of the infarcted tissue. Now, in another image, it is also suggestive of the decreased cerebral blood volume. So if the decreased cerebral blood volume is reduced along with cerebral blood flow, then the tissue is likely irreversibly damaged. That means this is the infarct core. Now these bright red areas, which are suggestive of prolonged MTT, it shows delayed blood transit, indicating ischemia as well as penumbra. Hopefully you will be able to deal with how to identify these penumbra as well as the ischemic core. Now, on the other hand, if you look at this NCCT image, there is no change except for the subtle hypodensity in the left middle cerebral artery region, which may correspond to the early ischemic stroke, but there is no obvious hemorrhage which is seen in this case in NCCT scans. And if you go for CTA, then there is a presence of the occlusion of a large vessel, which is MCA. So this is how the penumbra as well as infarct cores are identified. Then avoid aggressive therapy because it carries a high risk of hemorrhage. If the patient is having a large penumbra with a small infarct core, then obviously you have to go for thrombectomy if large vascular occlusion is present. If there is no significant penumbra present, then go for ITPA only if the patient is presenting within 4.5 hours. So how it is helping you out in the management decision which is based on the imaging. So as we have already seen that first you have to go for the NCCT head. It will decide whether the patient is having hemorrhage or not. If there is no hemorrhage, consider ischemia. Then you have to go for identifying whether the large vessel is occluded or not. This large vessel occlusion is based on identifying on CTA. Once you have identified the vascular occlusion, then you have to look for whether the brain tissues are salvageable or not. That means there is an infarcted tissue or a salvageable brain tissue. So this is to be identified on CTP. If you have identified the brain tissue to be salvageable, then obviously you go for the mechanical thrombectomy procedures. So this is the management decisions which is based on imaging. So again, if we look at how it is being written over here, that step 1 obviously is the non-contrast CT image. Step 2 is CT angiography for the identification of the large vessel occlusion. Step 3 is CT perfusion for the assessment of the penumbra versus the core infarct. So if salvageable brain tissue is present, then go for thrombectomy. And finally, how to proceed with thrombectomy is on digital subtraction angiography, which is performed only if thrombectomy is planned and it is used during the procedure. So if you go back to the question that the stroke team is considering thrombolysis or mechanical thrombectomy, which of the following imaging modalities would be the most appropriate next step in evaluating this patient based on the eligibility for reperfusion therapy? So obviously now you can very clearly identify that option number 1 obviously is not the correct answer, because non-contrast CT scan alone is just for the identification of the hemorrhages. So it is already done to rule out the hemorrhage. While DWI MRI imaging is highly sensitive for early ischemia, but it does not assess the large vascular occlusion directly. So it is less practical in the emergency because of the time constraints. The digital subtraction angiography is an invasive procedure which is used during mechanical thrombectomy. So it is not a primary diagnostic tool. The CTA is obviously the faster and the non-invasive one. And therefore, the answer for this question is CT perfusion with CT angiography. I hope you have understood the session. You have understood the investigations which are required along with the critical indications. All the best for your future examinations. In case if you do not want to miss any update related to NEET PG 2025, then please join our Telegram group. Thank you very much for listening.